And our next speaker is Dr. Jamie Studts, professor in the Department of Behavioral Science at the University of Kentucky College of Medicine and assistant director of cancer prevention and control within the NCI-designated University of Kentucky Markey Cancer Center. Dr. Studts is a licensed clinical health psychologist. His work involves development and testing of interventions to promote informed shared decision-making and behavior changes among patients and clinicians regarding prevention, screening, and survivorship of lung and head and neck cancer. Dr. Studts serves as the American Cancer Society's National Lung Cancer Roundtable Chair of Survivorship, Stigma, and Nihilism Task Force. So I actually saw a presentation of his at the International Association for the Study of Lung Cancer conference last month about the stigma, and I was really intrigued by that. So Dr. Studts, please.
Thank you very much. It is really an honor to be here at this event. This is my first opportunity to be here. And I think the first very striking thing for me is the passion, the enthusiasm, the excitement, the hope that has been presented by so many speakers about exciting things that are transforming our world of lung cancer prevention and control and care and outcomes. And we've probably all been to more than one very somber event, and that is changing when it comes to lung cancer. And so that's one of the most exciting things for me as someone who has been in this field for a while now. I want to build on a few things that have already been mentioned. One is, of course, as a researcher, I am fully supportive of the investments in research that have come about in the last decade or so and continue to come about. But we reduce that research to trivia if we don't use it, if we do not implement it, if we do not make it accessible to people, to Americans, to everyone across the world. It becomes nothing but trivial pursuit. And part of that is really starting to think about ways of implementing our research as we're doing it. And so the whole field of implementation science and really starting to think about these questions about dissemination as we design our research projects is a very important thing that makes it relevant to our community and really helps us transform what we know is the current landscape of lung cancer prevention and control. The excitement comes from a time when we have innovations at every single step along that lung cancer prevention and control continuum. And we've each have our focus in those areas. But if you think about it, there's innovations in tobacco control, both policy-wise and implementation-wise. Early detection, we've tons of innovations in that space. Molecular tumor profiling, immunotherapies, targeted therapies, new surgical approaches. This is profoundly important that we can take more individuals to the OR with the confidence that we can resect tumors and people can live longer. Stereotactic radiotherapy. And one of the things that we haven't talked enough about is Jennifer Temmel's earth-shattering research on palliative care and supportive care that can improve quality of life and extend well-being for those individuals who have been diagnosed and are nearing the end of life. This is incredibly important. As we get better and better with early detection and treatment, we need to be focusing on survivorship. We need to be prepared for a massive groundswell of lung cancer survivors, and how do we help them maximize their potential and their quality of life and their well-being and engage them in advocacy efforts, because they're going to be with us. And that's going to be incredibly exciting. So this room is going to be way too small in the future because we're going to have so many advocates who are here to support this cause that we feel so passionately about. But none of that is going to be possible unless we come through what Dr. Smith called as a storm. I refer to it as a cloud of lung cancer stigma. That dampens every single one of these innovations' potential to transform our lung cancer community and our outcomes. Lung cancer stigma impairs people from quitting. It impairs people from testing. It impairs people from talking to their patients about lung cancer screening. It impairs people from talking about tumor profiling and helping people access innovations in care that really can improve their outcomes. These subtle and sometimes not so subtle biases are dramatically important, and we must address them at every single level within every segment of society. And we will have to learn to provide radical levels of empathy and support for those individuals at risk. There is no shame that is going to help them quit. It is only through empathy, support, and the bringing forth of resources that is really going to transform risk in that way among tobacco users. In the same way, approaching our clinicians, helping them transform their practices and integrate evidence-based lung cancer prevention control strategies at the same levels that other screening modalities are integrated into regular practice. And helping expand options and awareness into rural communities. I really appreciate the efforts of the American Lung Association, the American Thoracic Society, to be thinking about how to implement this in lung cancer screening in rural areas, in community settings, where we may not have a CT radiologist to read all of our screens, but we can work with programs and to make sure that we are not dooming our rural community areas to suboptimal lung cancer screening, and which we really hope will reduce those rural-urban disparities in lung cancer outcomes that we see. And so I think to slow down and stop and to think, this is very exciting, a trajectory. We're on the precipice of major, profound change in lung cancer prevention and control. And I think one of the key elements to really harnessing all that value that our research dollars have generated for us is confronting the stigma, bringing forth radical levels of empathy, compassion, and support, not just for those individuals who've been diagnosed as well as their families, but the individuals who are at high risk, and we can help and support their efforts to access care. So, thank you.